Good afternoon from Miami Beach. This is Dr. John Bennett for Neurosurgical TV, the headquarters here. We have the pleasure today of having Dylan Djiofack, a medical student from Cameroon. And we have a guest panelist. Let's introduce Nathalie first. Hello, Nathalie. Just unmute yourself.
Hello, John. Hello, everyone. I am Nathalie Christel Gomsi. I'm a medical doctor in Cameroon, and I'm also a member of the African Future Neurosurgeons.
Very good. The AFAN, Association of Future African Neurosurgeons. And welcome. And welcome, Dylan. Thank you for presenting, and it's all yours.
Thank you, John. I'm Dylan from Cameroon and final year medical student and member of the Association of Future African Neurosurgeons. So today, as part of our series on the neuroanatomy lectures, we're going to be talking about the surgical anatomy of the midbrain. Let me just get this here. Going to be talking about the surgical.
Okay. You're going to get a large screen, right?
Let me get ready.
Okay.
Okay. Is it okay?
It's still not big like it should, like you usually get it.
Okay, let me get.
Yeah, I think at the bottom there,
Okay.
one of those. There you go. There you go. Perfect.
Okay. So talking of, in order to reach our objectives concerning the surgical anatomy of the midbrain, we're going to go through a plan in which we have an introduction. We have a little talk about the embryology. We have the description of the surgical anatomy, and we are going to go through a few surgical approaches concerning the midbrain. So, as we can say, the midbrain is that most rostral or most cranial part of the brain stem, since the brainstem is made up of 3 parts, so it is that most cranial or most rostral part of the brainstem that originates from the primary brain vesicles. So initially at about 3 to 4 weeks gestational age, we have 3 primary brain vesicles, amongst which we have the prosencephalon, the mesencephalon, and the rhombencephalon. So as we can see here, all through the development, the mesencephalon stays the mesencephalon and will give rise to the midbrain. So in this midbrain, we have posterior and anterior part from which the neural cells from the ventricular zone forming an intermediate zone will be responsible of the formation of the alar plates posteriorly and the basal plates anteriorly. So these plates are the main structures that are going to pursue the development of the different intramesencephalic structures till the formation of an adult midbrain. So besides the development of this intermediate zone into the alar and the basal plates, we have the marginal region, the marginal layer, which is invaded by fibers originating from different layers of the central nervous system, amongst which we can talk about the cerebral cortex. So these layers, these fibers, these neural fibers later on are going to be diverted laterally to form the crus cerebri. So the alar plates and the basal plates are going to be those structures that will be responsible for the formation of the different nuclei and the white matter fibers present inside the adult midbrain. So the alar plates are going to be responsible for the formation of the posteriorly the superior and inferior colliculi, which are part of what is known as the quadrigeminal plate, and anteriorly they will be responsible for the formation of the red nuclei on both sides and the substantia nigra on both sides. Meanwhile, the basal plates will be responsible for the formation of the somatic efferences of the oculomotor and trochlear nerves, and the visceromotor efferences for the third cranial nerve, precisely the Edinger-Westphal nucleus, be originating from the basal plate. So those are practically or mainly the essential structures present in the midbrain, and that will be originating respectively from the alar plates and the basal plates till the formation of an adult midbrain. So talking about the external morphology of the midbrain, we can say that the midbrain is that structure that extends superiorly from the diencephalon above and is limited inferiorly by the pons, anteriorly limited by the exit of the crura cerebri from the cerebral hemispheres, from the cerebral hemispheres just above, and the caudal edge of the mammillary bodies. And caudally, it is limited by the entry of each crus at the level of the basal pons. So one of the most recognizable or most essential structures present at the anterior surface of the midbrain is the crus cerebri. So there are two of them. They are the crura cerebri. So there are these structures that emerge from the cerebral hemispheres above, just below the optic tracts, you can see here, converge medially as they go through the mesencephalon and enter or terminate at the level of the basal pons. So surgically relevant is to note that medially to each of these crus cerebri, we have the third nerve, the third cranial nerve, which is the oculomotor nerve, and it is present here on both sides inside what is known as the interpeduncular fossa. And so this interpeduncular fossa is in very close rapport with the interpeduncular cistern, which contains cranial nerve number 3. As we said, it exits medially at the level of each crus cerebri medially, and it goes through this interpeduncular fossa and the interpeduncular cistern. And also, apart from this cranial nerve number 3, it contains the upper branch of the basilar artery. So this basilar artery resulting from the union of the two vertebral arteries. So here we have a better image that depicts the pathway of this crus cerebri. So as they originate from the cerebral hemispheres just below the optic tracts, the optic tracts, they go medially at the level of the midbrain and go through the pons. So the area that is of interest to us is mainly this region from the basal pons till the inferior part of the optic tract, which is going to be part of this midbrain. So here we see it better. It is anteriorly at the level of our midbrain. So going further at the level of the posterior aspect of the midbrain, we have very prominent structures. First, we have 4 elevations, which constitute what is known as the corpora quadrigemina. So in these 4 elevations, we have 2 rostral elevations, which are called the superior colliculi, and 2 caudal or inferior elevations known as the inferior colliculi. So these 4 elevations constitute what's known as the quadrigeminal plate, the corpora quadrigemina, which originates posteriorly from the alar plate. So marking the junction between the midbrain and the diencephalon is the posterior commissure here, and marking the junction between the midbrain and the pons below is the exit of the trochlear nerve, generally inferiorly here. So one other important structure that we can visualize at the level of the posterior surface of the midbrain is the pineal gland. That gland that's responsible for the production of melanocortin, essential hormone for sleep, and that's usually the site of certain endocrine tumors, be it at the level of the child or even at the level of the adult. So this pineal gland extends posteriorly between the two elevations, be it between the elevation of the superior colliculi. So be on the left and the right side between the 2 elevations of the superior colliculi. So here we see it better. We see our superior colliculus on one side, both of them superior colliculi, inferior colliculi on both sides, and between the two elevations of the superior colliculi, we have the pineal gland, endocrine gland. And then one important structure that we have to note here, or two important structures, are the superior brachium and the inferior brachium, which are those structures located laterally, superolaterally to the superior and the inferior colliculi respectively, and that permit connection between the superior colliculus and lateral geniculate body, and the inferior colliculus and the medial geniculate body. So here again, we can visualize the cerebral peduncle, which is generally a name used to replace the crus pedunculi, but it's not really that appropriate, because the crus cerebri is mainly made up of those fibers, mostly made up of those fibers originating from the cortex, those descending fibers mostly. So here we have a view of the posterior part of our midbrain. Here again, we see the superior colliculi and the inferior colliculi. And here we have our intercollicular region, which is a very relevant region in surgical approaches. Here again, we have the intercollicular region, the superior and the inferior colliculi. And here we have our inferior brachium and the superior brachium a little bit removed surgically. So talking about the internal morphology of our midbrain, we have to note that in our midbrain, we have white matter fibers, we have a nuclei, we have a gray matter, we have gray matter neurons. So these different structures can be organized into three main regions, which are the tectum, which is the roof of the midbrain, mainly represented by our quadrigeminal plate made up of our two superior colliculi and our two inferior colliculi. Next, we have second region, the periaqueductal gray matter, which is, as the name implies, that gray matter, assembly of gray matter neurons present just around the cerebral aqueduct, just surrounding the cerebral aqueduct. And then the third region, we have the tegmentum, which is that part, that anterior part of the midbrain that extends from the inferior part of the tectum till the region behind the substantia nigra, and we better seen in the transverse skirt of the midbrain. So this posterior part, it is to be noted that the posterior part of the midbrain is also in close rapport with the quadrigeminal cistern, posterior superiorly. So here we have a transverse skirt, as we were saying. We can see the three regions. We have the tectum, the quadrigeminal plate. Here it's to be noted that we are looking at the inferior colliculus on both sides, inferior colliculi. We have the periaqueductal gray matter, which is part of our reticular ascending activating system, that one of those main structures that controls conscience. And then we have the tegmentum that extends from the inferior part of the tectum till that portion behind the substantia nigra. So generally in documents, they say it extends till the substantia nigra, but doesn't include the substantia nigra. So the substantia nigra is not part of this tegmentum. Here, going a little bit into details into the tectum, as we said, it is also called the quadrigeminal plate, located mainly by this superior and inferior colliculi. And so it should be noted that the superior colliculi is part of the visual system. So it is a main relay structure for the fibers originating from the optic tract as they go through the lateral geniculate body and terminate at the level of the superior colliculus, then leave from superior colliculus till the Edinger-Westphal nucleus for the photomotor reflex, so the light reflex during clinical evaluations. And then we have the inferior colliculi, which are, on the other hand, part of the auditory system. So they receive fibers from the contralateral cochlear nucleus, from the dorsal and ventral nuclei of the lateral lemniscus, from the contralateral and ipsilateral superior olive, that part of the medulla oblongata, from the ipsilateral medulla, from the ipsilateral, medial superior olive, and the descending projections from the cortex. And so they are connected as part of this auditory system. They are connected to the medial geniculate body by the inferior brachium, while the superior colliculus is connected to the lateral geniculate body as part of our visual system through the superior brachium. So here we have an image that depicts the connections, as we were saying, of the superior colliculus. So we have our superior brachium, or brachium of the superior colliculus. We have the lateral geniculate body, and we have the fibers originating from the optic tract. And part of those fibers will go through the lateral geniculate body and terminate at the level of the superior colliculus through the superior brachium, at the level of the superior colliculus, and then exit from the superior colliculus to the Edinger-Westphal nucleus for the photomotor reflex, or the light reflex. Here, on the other hand, we have an image that depicts the connections of the inferior colliculi on both sides as they receive fibers from the cochlea, be the ipsilateral or the contralateral cochlea, and then, as we'll see later, from the lateral lemniscus. Talking about the periaqueductal gray matter, as we said, it is that gray matter, that assembly of gray matter neurons that surrounds the aqueductal, the cerebral aqueduct. And then the tegmentum, as it extends from the inferior part of the tectum till the substantia nigra, but without including the substantia nigra. So in this tectum, we can find, depending on the level at which we are in the midbrain, we can find our red nuclei. We can find different fibers, be they ascending or descending fibers from the cerebral cortex or to the cerebral cortex or the thalamus. And we can find various nuclei along this tegmentum. So a transverse cut through the caudal portion of the midbrain depicts the inferior colliculus. Here we have our inferior colliculus, which is actually made up of a pericentral nucleus, an external nucleus, and a central nucleus, which constitute this inferior colliculus. We have the trochlear nucleus here, and we have the decussation of the superior cerebellar peduncles. So apart from those structures, we have other parts of our descending and ascending white matter systems. We have the medial lemniscus, the anterolateral system, which is part of those fibers which we're going to see later on. We have the anterior trigeminal fibers, which cause here. We have the decussation of the superior cerebellar peduncles, still inside our tectum. So talking about those pathways that go through the midbrain, actually there are ascending and descending pathways. So the medial lemniscus, which is part of those ascending pathways, as we can see here, we go through the midbrain, originating from the sensory receptors at the level of the superior and the inferior part of the body. We have the anterolateral system, which carries the nerve impulses for the pain and temperature sensation, which is going to go through our midbrain here. Here we have the fibers right from the spinal cord through the medulla oblongata and the pons, and then goes through the midbrain just beside the medial lemniscus. We have the posterior and anterior trigeminal thalamic tracts, those tracts that receive the sensory innervation from the face mainly. So here we see in blue, here, And then we have the medial longitudinal fasciculus as part of those pathways. So here in detail, we see the corticospinal tract, which is part of the rather descending pathways. Sure, we didn't mention it, but it's part of the descending pathways from the cortex, internal capsule, right through the brainstem. And as we are concerned by the midbrain, it goes through the anterolateral part. Yes, we're talking about the crus cerebri. So the medial and lateral lemnisci, here again, we have our midbrain. They cross side to side with the medial lemnisci and the anterolateral system with the innervations from the pain and temperature sensations that go to the thalamus and then to the parietal cortex mainly. And then here we have the trigeminal thalamic tract, receiving nerve sensation from the face, going through trigeminal nerve, and then later on ascending to the thalamus and then to the parietal cortex. So our midbrain has rapports or relationships with various structures. So it has neurovascular relationships, it has cisternal relationships, which are very relevant structures during the surgical approaches to the midbrain. So talking about the neurovascular relationships, we have here we can identify our cerebral peduncles, crus cerebri anteriorly, and then we realize that they are in close relationship with one of those three neurovascular complexes of the midbrain, of the brainstem. We're talking about the upper complex, which is made up of the superior cerebellar artery, the midbrain itself, and then the cranial nerve number 3, 4, and 5, respectively the oculomotor, the trochlear, and the trigeminal nerve. We have posteriorly the cerebello-mesencephalic fissure, that fissure that exists between the midbrain and cerebellum, above which we can see the quadrigeminal cistern. We have the superior cerebellar peduncle, and then the tentorial surface of the cerebellum. Talking about the cisternal relationships, just about on every surface of the midbrain, we have these cisternal relationships, which means all of these structures are relevant because in access, be it to the tectum posteriorly, tegmentum anteriorly, or other portions of the midbrain, we have the substantia nigra here. Knowing these cisternal anatomies will be important, as most often they will be crossed by the surgeon in order to access the midbrain. So amongst these cisterns, we have the quadrigeminal cistern. As the name implies, it's just around our quadrigeminal plate. We have the ambient cistern. We have the crural cistern just anterior to the crus cerebri. We have the interpeduncular cistern between the cerebral peduncles. Here we have an image that depicts our interpeduncular cistern here mainly. And then laterally posterior superiorly we'll have the quadrigeminal cistern, which are mainly the two main cisterns, anteriorly and posteriorly. Here again we have an image that depicts our interpeduncular cistern, our ambient cistern anterolaterally, quadrigeminal cistern posteriorly, and then ambient crural cistern anterolaterally, again at the level of the crural of the crus cerebri. So what about the surgical approaches? Actually, during surgical approaches to the midbrain, what is essential or what's important to consider is that, first of all, this is one of the main structures of our brainstem, which we know the brainstem is that structure of the central nervous system in which we have many centers for control of the vital organs and the normal functioning of our nervous or neuroendocrine system. So access to this region actually is related to a lot of blood vessels, it's related to a lot of cranial nerves, and most often the tumors, or I'll talk directly about the tumors. Most of the tumors in this region will be associated to either compression of the cerebral aqueduct that goes in the midbrain, which will be associated to a hydrocephalus, which are associated lesions that can make the surgical approaches to this midbrain a little bit risky, and the prognosis in tumoral lesions of this region is really not that good. So during surgical approaches, we have to consider the safe entry zones. So in this midbrain, what are the safe entry zones to which we can go, and the surgical approaches that expose best this safe entry zones. So among the safe entry zones, we have 3 main safe entry zones. They're actually the essential safe entry zones. We have the anterior mesencephalic zone. Anterior mesencephalic zone that extends between the optic tract and the optic tract and the corticospinal tract. It will be better seen in a transverse skirt. We have the lateral mesencephalic sulcus posteriorly extending between the medial geniculate body and extending from the medial geniculate body to the pontomesencephalic sulcus behind, and the intercollicular region, which, as the name implies, is between the two, between each colliculus. So at the level of the superior colliculus, it is between the left and the right superior colliculi, and inferiorly the left and the right inferior colliculi. Talking about the surgical approaches, we have the orbitozygomatic approach, the subtemporal approach, the median supracerebellar infratentorial approach, and the extreme lateral supracerebellar infratentorial approach. So going a little bit into detail with this, first of all, the safe entry zones. We said there are mainly 3. We have the intercollicular region, the lateral mesencephalic sulcus, and the anterior mesencephalic zone. Anterior mesencephalic zone, laterally corticospinal tract and the optic tract medially, and the tracts of the oculomotor nerve, and the lateral mesencephalic sulcus, and here the intercollicular region. Here we see anterior mesencephalic zone, lateral mesencephalic sulcus between the medial geniculate body, extending downwards to the pontomesencephalic sulcus. Yes, the pontomesencephalic sulcus. And here we have the intercollicular region between the colliculi on each side. So the anterior mesencephalic zone is mostly preferred for those anterior midbrain lesions. So lesions at the level of the anterior part of the midbrain here. And it's bounded medially by the oculomotor tract, tractus of the third cranial nerve, oculomotor tract, and laterally by the corticospinal tract. So this anterior mesencephalic zone takes advantage of the fact that between this corticospinal tract and the oculomotor tract, mostly the substantia nigra and the red nucleus are behind, giving a few centimeters of access to the surgeon for the anterior lesions of the midbrain. The lateral mesencephalic sulcus, on the other hand, runs downward from the medial geniculate body, as we said, the medial geniculate body, to the pontomesencephalic sulcus posteriorly. It is crossed by the posterior B2 segment, the medial posterior choroidal artery, the cerebello-mesencephalic segments of the superior cerebellar artery, the trochlear nerve in itself, cranial nerve number 4, which you can visualize here, trochlear nerve, and the tentorial H at the level of the tentorium cerebri. So all of these structures, be it the vascular structures or the nervous structures, have to be taken into consideration and protected during approaches to this lateral mesencephalic sulcus, which gives mostly, as you can see here, access to lateral regions at the level of the tegmentum of the midbrain. And then lastly, we have the intercollicular region between the collicula on each, the colliculi on each side, superior colliculi and inferior colliculi, and it is the most cherished area for small neurotomies, as between these two colliculi, there are very few fibers. So there's really little nervous damage during the surgical procedure, and the access is relatively easier for small neurotomies. So talking about the surgical approaches, we have the orbitozygomatic approach, which best exposes the anterior portion of the anterior portion of the midbrain, including the interpeduncular fossa, and the crus cerebri with the oculomotor nerve itself, and part of the inferolateral part of the lateral midbrain side. So this approach can be best used to expose the anterior mesencephalic zone for surgical approaches to the anterior part of the midbrain. On the other hand, we have the subtemporal approach, as the name implies, below the temporal lobe, which gives exposure to the lateral part of the midbrain, mainly the lateral part of the midbrain. So, yeah, mainly the lateral part of the midbrain, and it can be one of those procedures used to expose the lateral part of the midbrain for access to the lateral mesencephalic sulcus. And then we have the median supracerebellar infratentorial approach. As the name implied, it is medial curve above the cerebellum and below the tentum cerebri. So it gives access to this posterior part of the midbrain, through which we can have our safe entry zone, the intercollicular region, for access to posterior lesions of the midbrain. Thank you for your kind attention.
Okay, I'm sorry there. I'll sleep at the wheel. Once again, excellent technically. The photos are awesome. I couldn't imagine doing this kind of presentation when I was a student. And I'm interested to hear from two neurosurgeons that came, Dr. Corbulo and Dr. Marco. Sure, and Natalie too, but let's hear from the neurosurgeons on how they use anatomy of the midbrain. I'm sure there are certain pathologies that affects the midbrain. I'm kind of interested to hear. And then comes Naru, another neurosurgeon. Can you comment, Marco or Dr. Corbulo, on the importance of, greetings, Marco, how you doing? I get on, okay, Marco.
Hi guys.
Hello.
Sorry, hello everybody. For the delay.
Hello, Dr. Marco.
Well, I just seen the presentation, and I congratulate with colleagues for the beautiful panel and the beautiful anatomy you showed of the brain. That's usually an important aspect of the posterior fossa surgery, and also an important aspect during the middle fossa surgery. So I just want to say that's an excellent presentation, and obviously is as you just highlighted, surgery that need meticulous analysis of the best approach, depending by the pathology, obviously. Just that.
Thanks, Dr. Corbulo. Thank you.
That's Marco. We'll hear from Dr. Corbulo now. Hello, Dr. Corbulo.
That's Dr. Marco. Yeah, thank you. Hello, everyone. Thank you so much for this this great presentation. I enjoyed this anatomy is like the basis of neurosurgery or any surgery. When you want to practice surgery, you have to know the anatomy. You have to know where you are going, where you are not going. So thank you so much for the presentation. I wanted just to add one thing, like you were talking about those the relationship with the systems. The systems around the midbrain, especially the ambient and quadrigeminal system, they help us too much in case of traumatic brain injury when you want to decide either you want to do a decompressive craniectomy or not. Usually we check on those systems if they are effaced or they are compressed, and how many are they compressed, how many are patent. So they help too much for you to do a decompressive craniectomy. Thank you so much for this wonderful
Thanks, Dr. Kabulo.
Thank you, Dr. Kabulo. And Naru, how you doing today? Welcome from, I guess you're in Morocco, I'm not sure. But Naru, could you comment? I don't know how much of the presentation you saw. Go ahead, Naru, go ahead.
Hi, hello everybody, and thank you, Dylan, for your brilliant presentation. I'm sorry I come late, so thank you. It is nice to see you done this good job, because you are aspire to done neurosurgery, and it is very good to know anatomy, and I think it is good things what you do, and medulla oblongata, it is I see your presentation, but I come so late, so it is good. But like Dr. Kabulo said, it is very important to know this term, what she said, because I perform this craniectomy decompressive a lot of time, and I know that is very important to know that. So it is very nice to know your anatomy, because it is your way. So thank you for your presentation.
Well,
And
you know, Naru, I know you're busy, you came late, that's okay. We're just glad you came.
Yes, of course.
Can you tell us why it's important to know the anatomy of the midbrain, and where have you been in the midbrain yourself? Doing what type of operations have you done in the midbrain? Have you done any operations in the midbrain, Naru, in that area?
Yes, of course, yes.
Oh, okay. I don't know. I'm not a neurosurgeon, but what kind of pathology have you seen in the midbrain?
But like I guess, well, the first time, sometimes we follow this area to know if that is if you have compression of midbrain, and you can perform craniectomy decompressive. Sometimes you can have like a tumor, and we have to perform excision of the somato. We can perform we can say a pteronal approach, and sometimes we can perform about tumor. We don't have more experience. I don't have more experience about tumor but I know that it is the landmark to me about my systems to do my score, my CT score, to know if I will go to perform craniectomy decompressive or not.
Okay.
Okay.
I
have a question, John.
Go ahead.
For the neurosurgeons on panel, I'd like to know when you have a case of a midbrain tumor, actually, do you perform the surgery? And if yes, what's the prognosis of the patients after the surgery? Which approaches do you use in case you operate, and what's the prognosis in over there in your countries?
Okay, thank you. Maybe Dr. Marco want to answer, then I'll also give a comment. Dr. Marco, carry on.
Yeah, hi. Well, about the question, it does depend obviously by the tumor. We cannot forget that exists some low-grade glioma of the tectum that don't have any surgical indication, but just need a follow-up, and if there is a concomitant hydrocephalus, need a ventriculoperitoneal shunting or a 30 ventricular sternotomy. And other pathology, like some cases I saw during my experience, like cavernoma, that need, on the contrary, surgical approach when they bleed. So in this case, the safety zone are obviously the first choice in this case. Other pathology I saw when midbrain is involved is a case I remember of a guy's 25 years old. We implanted when he was newborn a ventricular peritoneal shunt. Unfortunately, this shunt infected. He has an infection because he was a vet, and he had a stranger infection caused by dog. I actually don't remember what's the pathogenous exactly. So we need to remove this ventricular shunt. A problem: this ventricular shunt going deeper until the sylvium aqueductum. So it was a problem to remove because there was the risk to get interaction the midbrain and so cause a disaster. So in this case, we perform endoscopically guided removal. We go in deeper until the sylvium aqueductum, and we perform a sort of lysis around the aqueductum catheter. In this, obviously, in this case, we can say that, and we are able to remove. Obviously, all the procedure was done performing evocate potential, and it was actually a great success. And at the same time, we perform a ventricular sternotomy, and now this guy is well-being, is also married, and has some children.
Wow. Congratulations.
Good to hear that story.
Great.
Yeah.
Yes. Thank you so much, Dr. Marco, for that wonderful operation. Yeah. They are like Dylan, your question, like Dr. Marco was saying, they are patients with the lesions in the midbrain, and you operate on them, they do well. But there are also other lesions where you can just watch and see. You follow up your patient, last time when they were presenting about anatomy, variant anatomy, I showed a case of midbrain cavernoma. Usually a case like that, you only go, let me try if I can share the image, Dr. John?
Yes, okay, go ahead.
Yes, can you see that?
Yes.
Yeah, you can see.
Like that's a cavernoma of the midbrain. Can you see it?
Yes,
you can see it, Dr. Kabulu.
Yes, you can see.
Yes, so like that one, you can do your supracerebellar infratentorial approach, which is going to allow you to see the posterior and posterolateral surface of the midbrain.
Excuse me, Dr. Kabul, could you use your pointer? You can use your pointer, you know. There you go. Okay.
Can you see it
Yes,
like
we
now?
can see your pointer.
Yeah, you can see it.
Yes. So this is a cavernoma of the midbrain extending in the lateral aspect of the pons, like you can see here. This is T1 weighted image on MRI. There is also another picture on the T2 weighted image. You see that here it looks like a bleed. It's a bleed. It's white. It's hyper-intense on T1. It was also hyper-intense on T2, which is like subacute bleed. Usually it's a cavernoma. At the first bleed, you see it like this. But if it starts to bleed several times, then we will see a rim of hemosiderin around there. So a hypodense rim around that lesion. So this one with the supracerebellar infratentorial approach, you can now see, you can go through it and visualize the posterior aspect of the midbrain and also the posterolateral. Like you were talking about safe entry zones. You mentioned about them, the anterior ones. They are also anterior, the posterior safe entry zones where you can go and access this lesion. But now for this patient, the patient presented with 1 day issue of vomiting, and the patient collapsed. He's a barber. He was shaving his client and started to vomit, and he lost consciousness, was taken at the local hospital where he got a bit of injections, some injections, and he regained consciousness, but he became hemiplegic. Taken to our hospital after resuscitation, the patient was doing well, no more neurological deficit. We discharged the patient and tried to see. But if there is now progressive neurological deficit, then, or intractable seizures, something like that, or signs of raised ICP, maybe that lesion can grow and obstruct the aqueduct. The patient can present with hydrocephalus. We might go for the hydrocephalus, or we can go for the lesion when there is progressive neurological deficit. So there are lesions in the midbrain where you can just watch and see, or you can just check your, do like a follow-up on the patient. There are also others where you can go and operate and the patient does well. Thank you so much.
Thank you, Dr.
Thank you, Dr.
I have a question.
Go ahead.
Yes.
Go ahead, Dr.
Yes, I just wanted to ask, actually we had a patient, a young child, I think she was something like 7. So hopefully in our countries, patients come to the hospital and sometimes it's already late. But this child came, let's say 3 months earlier. She was having, she was having hemiparesis with signs of compression. She was having a hydrocephalus, but it was not yet, she wasn't yet having signs of intracranial high pressure. So the child went and came back, let me just say 3 months later, and she was sometime kind of with an MRI, and she was, I think she was having a glioma of the midbrain. I think we saw that patient with I think the service actually to Dylan.
Yeah, we saw the patient.
I showed the patient, but the child was already in a very bad state. She was very unconscious. She was having some signs of engagement. She was decortication, so we couldn't do really much. What I want to ask is, if you want to follow up a patient like this child with a suspicion of glioma through the MRI, and knowing that you don't have means to operate, what do you think 3 months earlier could have been done to, let me just say, prolong, or let me just say add some months to her life, or I don't know, some years.
Well, can I answer? Worsening after 3 months is a very fast growing. So I like to see the MRI picture, but it seems like anaplastic glioma, I guess. But I've not seen the MRI, so it was anaplastic or even worse, a glioblastoma. Unfortunately, the prognosis is very bad.
Yeah, I think I have the image, but I don't. It's very far in my phone, so to check now will be a little bit difficult. But next time, I think I'll show it to Dr. Marco so that you can see. The child died 3 days later. Though we gave corticoids, we gave, let me just say, we put her in a position in which she could reduce the.
I have a question. Do you mean the hydrocephalus?
Yeah, she was having hydrocephalus.
Okay.
And because it was already it was already compressing the aqueduct.
Okay, that was obstructive hydrocephalus. Did you shunt the patient?
No, we didn't. Because let me just say, we had to. When cases arise like that to us, the family, we have to put the family we have to give a good counseling, because we usually tell them that we'll do the shunts, but that doesn't guarantee that the child will live longer. So usually they choose, let me just say, kind of standardization. They just choose the other way around, that we should leave the child. So that's what happened actually.
Okay. Well, in the next time, if you have the picture of the MRI, I think we can have a better understanding of what's the situation.
Okay.
Because it should be interesting to analyze the case.
Yeah, maybe if you still have those images next time, like maybe next Saturday, you can share them. Then we try to discuss. Yeah.
Yeah, I think I took the images. I'll try and show you next time.
It's okay.
Okay.
Sure. Any cases that are interesting, you guys are welcome. But I guess we're doing the series now, so we'll complete the series. If you want to have more, that's fine too. Or if you want to wait till it's ending, we could do you know, whatever you guys think is good educationally in the neurosurgery field. And I want to reiterate, you medical students. Well, there's one more student, I believe. Hawaii, are you there? Hawaii, I don't see your real name on your screen. Are you there? You want to make a comment? I see you're in your car participating. We appreciate that. Are you there? Can you hear me, Hawaii? Possibly. Go ahead. I'm sorry, I'm having hard time audio.
Et la sémiologie radioactive. Ça, c'est 1 mois, 2 mois, tu dois les savoir. L'anatomie, après l'anatomie, ça vient. L'anatomie, quand tu apprends la sémiologie, tu vas apprendre la sémiologie radioactive.
Can you guys understand?
Tu vas apprendre même l'anatomie.
I think he's not talking to you, John.
On va chercher à
Conversion.
Are you having a hard time here?
Ça, c'est pas normal. Il y a des gens qui font comme ça, aléatoirement. Aléatoire, c'est pas il peut avoir, au début, tu trouves qu'il a plus de niveau que toi. Mais, à la fin, tout confirme.
Is anybody understanding at all? Or is it me?
Ça va.
I don't
Okay.
I think that they call the talking with another person. You have to please unmute him. Yes.
Okay.
Mute.
Okay. Yeah. You students are lucky to be with 3 neurosurgeons on a Saturday. Man, oh man. Like I said last week, when I was in medical school, I hardly ever even talked to a neurosurgeon. Never mind spend an hour with them on the internet. Of course, we didn't have internet. But let me tell you guys 2 pieces of great news and the first one has to do with the African neurosurgical community. We are collaborating with Khalif Abdul from Nairobi, Kenya. Perhaps some of you may know him. We're in the process now of trying to set up the cadaver lab in Nairobi. They have an active cadaver lab now. What we're trying to do is to film it and to have good audio from the cadaver dissector, because the dissector needs really good audio. And so we sent some headphones, wireless headphones for the dissector to be able to comment while they're dissecting. Do you know what I mean?
Yeah.
Yeah, they need to comment and they need to interact. Like, for example, Natalie has a question. What's this? What's that? They can interact with you without fumbling with their hands and stuff. The hands are free, so they can dissect and point and comment on. So anyways, we're in the process of setting that up so that in Cameroon, you won't, I mean, obviously it's better to go to Nairobi, but sometimes you can't. So hopefully we'll be able to televise these cadaver dissections in an interactive. It's not just a video, it's going to be interactive, which adds another layer of value to an educational experience.
Yeah, that's a great idea.
Yeah, so hopefully we'll get that lab going and get people, students in Africa, access to cadaver lab. Because I know even in the United States too, sometimes you have a hard time getting to a cadaver lab. Because a cadaver lab needs, and we can talk frankly here, we're doctors, it needs a refrigeration system. You've got to be able to preserve the cadavers. So there's not many places that can afford to have a full-time refrigeration for cadavers, but Nairobi has a center. I don't know how many more there are. There's probably one in Cairo and possibly in Morocco. But we're certainly going to try to use that. And there is another piece of good news is we're having an app made which will allow people to watch these transmissions from their iPhone very easily. They'll just make, you can't see this here, but they'll just tap on the icon for the app and then tap one more time and they'll be watching the live presentation on their smartphone. And there'll be a link at the bottom. If they like the presentation, they can click it and enter it. What do you guys think of that?
Yeah, that's a good idea. That's a good thing.
Yeah, because
is that not for Android phones? Because
yeah, I'll send you the link. Well, I can't send links because I can't send links to foreign countries. I don't know, Facebook's restricting me, but certainly I'll email you the link to the beta of Android. And iPhone is being developed now. That takes another couple of weeks. But we hopefully that adds another feature to interactivity and accessibility. Ease of access is a big step in the internet. If you can make it easy for people to do things, they'll do it, most likely. And if it's hard, they won't do it. So hopefully we make it more accessible and easier to do. Sonatus, I didn't realize that now I see your picture. Hello there. Could you please introduce yourself? Hello, Sonatus. Hello. Can you hear me okay? Well, maybe you can't. Okay. Anyways, let me tell you, Sonatus Johnson, he's a medical student from Dominican Republic. And he'll be very active too. So, okay, that's great. Any closing comments, Marco?
I have a case, Dr. Marco and Dr. Kabule. Please, can you give me an idea of what could have been done? Okay. I wish to share a picture.
Oh, okay. I'm sorry to cut you off. Let's keep rolling, man. That's what we're for.
I don't know. Can you see the picture?
Yes, we can see it. Yes. Make it a little bigger.
Okay.
Well, you fell off there. You fell off there. Now.
Let me check. I'm using my my phone, so it's not easy.
Smartphone, yeah. You gotta get good at that.
Can you see the images?
Yes, it's good size too.
Okay. Actually, it is a 34-year-old patient who had a history of tuberculosis when he was something like 24, and who came 10 years later and was having a spinal cord compression. He was at with a score of McCormick at 3. That's he was working, but not all by himself. So on Monday we entered the theater. So since the only means that we have to try to drain and remove this is the posterior to the posterior and to do a laminectomy, simple laminectomy, just to decompress and to drain a little. So I just wanted to ask, could, with little means, because we don't have much, could we have done better, or what was the best approach to these patients?
Well, no, the posterior laminectomy is actually the best approach in this case. And the aspect it seems anyway quite bad. So I think you did the best things. Any report by the pathologist to us?
Not yet. They are very late. They are really due to scarce means. They do like something like 3 weeks to give us and anatomopathologic
A
sound.
pathological diagnosis.
Dr.
Yeah.
Bennett, Dylan is asking, you want to come in?
Oh, I'm sorry.
Okay.
No,
Then,
Dylan, I don't see him there. Okay, I'll try to get him.
okay, Christian?
Yeah.
Okay, do you do also like image guided biopsy?
No.
Radiologists, they don't do it. Like
Not
CT,
really.
CT guided biopsy.
No, they don't really do it.
Okay. You mean the patient is no
Actually,
longer
most
working?
of them they don't like, they do it for some other pathologies such as abdominal pathologies, but for neurosurgery, people are a little bit afraid.
Okay. Is the patient walking?
Yeah, he's a 3 on 5.
Is 3 on 5 power in the lower limbs?
In the lower limbs.
Okay. You mean he or she, is he a male or female?
It's a male.
Male. He was treated for TB 10 years ago.
10 years below, yeah.
That was pulmonary TB.
It was a pulmonary one.
Pulmonary, yeah. If you are suspecting like TB now, I think he has to get his anti-TB treatment and immobilization. You immobilize the patient. Surgery is not the first indication here. You treat your patient, then if possible, you can do your CT guided biopsy. You send to histology to get your result, your histology result. But if you are not suspecting TB, it's like something else because the image is too small, you can't see it properly. Then you can do your laminectomy like Dr. Marco is saying. It's fine. Yeah. Okay.
Okay, sorry.
Okay.
Thank you. I was just asking, could an anterior approach, could it be done an anterior approach to remove, to drain or to remove the lesions? I don't know.
Thoracic, can you go back to the image which is showing the lesion?
Please.
Yes. And
Okay.
approach in the thoracic region is not easy. There are many structures there. That lesion, you can still remove it from posterior. You do your laminectomy posteriorly, then you go and remove that lesion. Once
this
you
image
that sagittal, no, the sagittal image.
Okay. Yes. Wait.
Yeah, there we go.
I don't know.
You got it. You got it.
No, this is coronal.
Okay. Let me check. Sorry.
You rarely use the anterior approach, right? That's well, I'm not a neurosurgeon, but it's rarely used, only in the neck, right?
Yes, in the neck,
correct.
usually we do anterior cervical discectomy and fusion.
Yeah, but in the lumbar region, it's very rare, I think.
Yes, this one, can you see the one on the left? Okay, again. Yes, again. No, go back to that level where you were before.
Yeah, a little bit in the midline.
Yeah, this is lateral. Okay.
Okay.
Midline. This is more lateral.
Correct. Okay.
Can you go back again? Like go to the midline.
How should I do? I don't understand.
There's the image you just showed now.
Yeah,
That's it. This one. Oh, sorry, you went again. Go back to that one.
Okay. I should go back to the other? I don't know.
Yes, we'll tell you when to stop.
This one.
Okay. Is it okay?
No.
No, the other one.
The second one, this one?
Try to go up.
Up.
Upwards.
Yeah? Again. Okay. Stop.
Okay.
Yes. Stop. Stop there.
No?
Okay. Perfect. Yeah. Don't go fast.
Okay. Can you stop there?
Okay.
Perfect.
This is T1.
Yeah, exactly.
Where you can see hyper-intense lesion on the vertebral body. It is not labeled. Then within the canal, there is that huge lesion, which is also hyper-intense on T1. There is also pre-vertebral lesion, which is also hyper-intense there. Then there is reduced disc space between that vertebral body with the hyper-intense lesion, with the one above. Yeah. So do you have the image on the T2 image?
Oh, sorry. I don't think I took all the images, but let me check.
Yeah.
Let's also image. Yeah, I think I took. Is it okay?
Yes. Then this is still T1.
T1. Yeah.
Oh, sorry. It seems as if this is the only bit that I took about.
Okay, the one above. That one above. That's T2. The one above.
Okay.
That's T2.
Okay. I didn't really take enough images, so sorry.
Yeah, there is chord compression.
Yeah, there's chord compression.
Yes, can you see that line of CSF, the white, which is not going up to down there? And there is also signal change within the chord. That those two vertebral body, they look hyper intense with that deposit.
Was T5 and T6?
Sorry?
Was D5 and D6?
What's this?
T5.
It was between D5 and the vertebra, the T5, T5 and T6 was between.
Okay.
Dorsal 5, dorsal 6.
T5 and T6, okay. Yes. But yes, we can think of TB, but it looks unusual to be TB. Did you check if there is like a primary lesion somewhere there?
No, is that we collected due to his history of treatment of TB, pulmonary TB in 10 years earlier.
Okay. Yeah.
And it's very frequent in our country. So.
Sorry?
There was an epidemiologic argument, and there was also some signs of impregnation of tuberculosis, like night fevers, night fevers and sweatings, chronic night fevers and sweatings.
I think our senior Dr. Mako will try to give also his comment. I think immobilization, you give a thoracolumbar corset, you start the patient on anti-TB. Now they are even talking, you can go up to 18 months, the lowest, which is like 12 months of anti-TB. Usually with TB, the patient, they recover. They recover after treatment, and the surgery is not the first modality of treatment for TB spine. I don't know, Dr. Mako is our senior, he can still add something.
Well, actually, I have a few experience about case of POTS disease, so TBC disease in vertebra. I just saw a case during my experience of Pakistan guys, but the vertebra were already crushed, so we perform also a vertebrectomy, but it was a dorsolumbar aspect, so we perform a retropleural approach. In this case, anyway, I perform first of all laboratory exam like quantiferon to see if there is a tuberculosis miliarius, I guess is the terms. So a diffuse tuberculosis, and I start the anti-tuberculosis therapy. And then the posterior laminectomy is actually mandatory, because if there is a spinal compression, you just need to decompress. I don't know, then as I just told you, I don't have so much experience, so I don't know if the only therapy can reduce decompression in the spinal cord. By the way, I guess the spinal cord decompression is absolutely unstable to try to save the leg patients and the motility of the patients in the lower limbs. Then the involvement of the vertebra, I won't perform any vertebrectomy, but just as I just told you, Cabulo, immobilize using the cast, and to see what we get from the laboratory exam about tuberculosis, or by the pathological exam, this is a neoplasia and what sort of neoplasia is, and then start the therapy. Anti-tuberculosis or chemotherapy was the result of the pathological exam. That's my opinion.
Okay.
Yes, thank you, Dr. Marco. Yeah, so Crystal, it was better if the radiologist could do CT guided biopsy. So you name first your lesion, yeah, then you do it.
Okay.
Okay. Thank you very much.
Thank you, guys.
Thanks.
Okay. Let me get you off the screen share. You want to discuss this image anymore, Ethel?
Yeah, you're right.
Okay, I'm just going to bump you off there. Let me just share this. Okay, get out there.
And
okay.
Today is the birthday of one giant of neurosurgery, the father of modern micro neurosurgery, Professor Yasaju from Turkey.
Yeah. Happy birthday.
Yes. One of the big. I don't know, Dr. Marco, have you met him before?
Yazargia. No, I don't have this lucky.
So who's that again, Dr. Cabulo?
Professor Yasaju.
Mahmoud Ghazi Yazargia.
Oh, yes, sir. From Istanbul, right? Turkey?
Yes, yeah. I met him twice in Istanbul.
Yeah, you went to Istanbul, yeah.
Yes, I met him twice in Istanbul. He's great. You know, even yeah, that's him.
He's a legend.
Yes, he's a legend. The father of modern micro neurosurgery.
He's 96 years old today.
He's now 94.
94.
Is he still operating?
He's still operating, yes.
94 years old? Oh my God, there's hope. There's hope.
Yeah, but John is not a usual neurosurgeon. He's a god. He's a god.
Yeah. I've seen pictures of life with him. I knew the name, but I didn't realize he was so big.
Oh, yes, he's too big, this one. So what I like at his hospital, he has his engineers in theater. The time he's operating, if he can't reach a lesion, he's telling the engineer, you see now I like an instrument like this, so I can reach that instrument. And after 1 week, 2 weeks, they will make an instrument for him.
Really?
So he's operating
Wow.
with his engineer in theater. Yes.
Well, I imagine under the microscope, you need good visual acuity, right? Your eyes need to be pretty good, right?
Yeah, and his hands too. I never meet him, but I hear some stories about colleagues that work with him, and he's incredible. He operates alone the aneurysm. He perform using bipolar forceps, microsensor. All the procedure is absolutely great, and he don't care about the form. If need to get down on the knee to see better, he get down on the knee. Is incredible. He's a very my colleagues define him as the great mobile neurosurgeon because he's moving in all the positions to perform surgery. But it's incredible. It's absolutely incredible.
Well, I hope all on the panel are operating at 94. I hope they all are. That's amazing.
Yeah.
Amazing.
Yeah.
I never realized. I seen his picture. I never realized he was 94.
Yeah. I think that only Harvey Cushing was compared to Yazarian.
Yeah. Sure.
Wow.
Yeah.
Jesus.
That's tremendous.
He's a giant.
Well, we'll try to get him on the Cameroon Weekly webcast. You never know. We might get lucky someday.
That would be excessive love, John.
There we go. Okay. Thanks. It's a great session, great interactive session. The real power of this platform, which was used today. I appreciate the neurosurgeons coming out and Dylan for preparing a very good, very excellent presentation. And hang around, guys. We'll chat a little bit, and we'll just wrap this up formally. Thanks, Dr. Cabullo and Dr. Marco, and Dylan and Natalie.
Thank you too, guys.
So much.
Thank you.
Bye.